So as you go through this, as you rewatch, as you start to kind of like let the things I'm saying marinate and practice some of the things, please go into the Facebook group. Shoot me, if you don't do Facebook, shoot me an email with questions or concerns or clarification or whatever, and we can definitely address those. I want everyone to feel like you know what's going on and that you're confident and kind of up to speed with all of this stuff. This is a lot of information and probably new to a lot of you. We're going to really focus on pelvic floor, breathing, the mechanics of what's going to happen in birth, and how we prepare our bodies for it. So, in contrast to traditional birthing classes, this is going to be a lot more focused on you and movement and muscles and breath and labor positions and options and knowledge and data and science and facts on what to expect and what can happen, and really just kind of focusing on like the rehab part after and how to get you ready for delivery. I have a midwife coming in to do a session on kind of the medical side of things. She'll talk about medications, she'll talk about VBACs. We'll go through C-section in two of the sections. She'll talk about kind of like what's happening on the medical side of things, stages of labor, cervical effacement, what it's like when your water breaks, like all that stuff. And then the rest of our sessions together really will be like the physical prep and rehab. Okay, so it's a little bit different than traditional birthing classes, but super important. I'm so excited. All you guys are here. Let's just get going. And if anybody needs like a break or have a question, just shoot it up in the chat, and we'll get going. All right, y'all. You ready? I'm going to share this screen. I'm going to close this Q&A box just because it's too distracting. But put something up in the chat if you have a question. All right. So let's go ahead and get this going. And then, okay, perfect. All right. So can everybody see that okay? Let me know in the chat if you can see that and if you can see me and if it's clear as mud. Yes, looks good. Okay, perfect. Thank you. Okay. Hey, Beth. Okay, so here we go. So this is our first session. The outline is also up on Thinkific, so you can see what each session we're going to be covering. So today is our first one. Let's go. There we go. Okay. So just copyright real quick. The images are from my own designer, and I also have a license for Canva, Unsplash, and 123RF, so they're all copyrighted. And this is all copyrighted by my company, Marcy Crouch LLC. Okay. So here's something to think about. I just kind of want to talk about this as we go forward. So everyone's at different stages of pregnancy, and everybody's different in terms of like what your baseline is, what your exercise tolerance is, what your fitness level, health, that sort of thing. So as we progress through the class and we start to do some like really basic pelvic floor exercises and we start to do some internal vaginal prep work, I just want you to make sure that you have clearance from your OB that it's safe for you to be doing any sort of internal work and any sort of exercise. Okay. Usually, if you are not on pelvic rest and you are cleared for all your activity, then what we'll be doing to the perineum and the pelvic floor is like super safe and very gentle. We don't go anywhere near the cervix, but we will be working internally. So if you have an active infection, yeast, UTI, BV, if your water has broken, if you are bleeding, and if you have been told not to put anything into the vaginal canal, such as a penis, if you're on pelvic rest, then we probably shouldn't be doing internal work, but just make sure that that's cleared with your physician before we start doing that. I'm not an OB. I am a doctorate level pelvic floor physical therapist. I have a board certification in women's health. I have advanced training in this population, but I am not a medical doctor. So I can't prescribe medication. I can't perform surgery, that sort of thing. I don't do pap smears, although I'm up in there most of my life. So please make sure if you have any medical questions, if you're concerned about anything in the pregnancy, talk to your doctor, your healthcare provider, your midwife, whoever you're seeing. You can always bounce ideas off of me also, but your doctor is your first line of defense. Okay. The other thing I want to talk about as we move forward here is that we prepare. This is what I tell my patients all the time. When we're preparing for birth and training for birth, we try to prepare for everything that we have control over, but there are a lot of things that we don't have control over, and sometimes things happen during delivery and labor that we can't prepare for and that we can't foresee, and that's okay. My job and what I want you guys to get out of the course is to really give you knowledge, facts, data, all that good stuff, so you can make informed decisions and you know what to expect. So you don't feel like you haven't heard this before, or this is like a new situation, or you're not sure where to go with this. I want everybody to kind of know what's coming and know what to expect. So the decisions that you make with your provider are you're comfortable with. Okay. I don't judge any type of birthing choice, or any sort of decisions or whatever your plan or preferences may be. My job is to educate you, prepare you in the best way possible, and make sure that you're set up for success afterwards. Okay. Everybody has different plans and preferences and ideas of birth. And we're going to talk about this a little bit more as we go through the whole course, but just know that there's no wrong way to birth. So whatever happens, whatever you decide, whatever path your labor and delivery go on, it's okay. We will all kind of come together and work and support each other, and you'll have a plan in place, and you already have a team, and you already have me here to help postpartum. So just kind of take that with you as we go through the course. All right. So here we go. I have to click. Okay. So just a little bit more on what we were saying earlier. Plans can change last minute with delivery for sure. Um, so I think it's always a good idea to talk about having preferences for your birth and having kind of backup plans. So as we go through the course and as you kind of learn about all these different scenarios, you can start to think about what you feel comfortable with and what your doctor might be comfortable with for you, and what kind of standard practices. And we'll talk at one session, I think it's the fourth session, questions to ask your provider, and kind of get an idea of wherever you're birthing, whether it's a hospital or a birth center or your home, or kind of how they do things and what to expect. So we'll talk about that a little bit later. But things to keep in mind as we move forward is that we want to have preferences and not like a hard set birth plan, because things are fluid, the body is fluid, this is a live moving event. So sometimes when we have a super strict plan and things don't go according to what we are envisioning in our heads, then there can be a lot of trauma associated with that, and a lot of like mourning and guilt and feeling like you failed in some way. And that's not the case. Like, for example, if you were really wanting a non medicated vaginal birth and you end up having a medicated vaginal birth, that's okay. Like, you make these decisions, and every decision is going to be just fine. And the most important thing is that you are safe and your baby is safe. Okay. And that you are feeling supported and empowered and not like bullied into any sort of decision or situation. I've had tons of mamas who have wanted to do unmedicated vaginal, and they end up having an emergency C-section, and things happen. So that's okay. We're going to get through it, and I'm going to prepare you for kind of all these different scenarios and what to expect, so you know what's coming. All right. So the other thing is that I am, like I said, I'm very non-judgmental. I feel very grateful that we have the NICU, that we have C-sections, and that we have medicine. So whatever your preferences are, if you want medication, if you don't want medication, if you want an IV, if you don't want an IV, and we'll kind of talk about this as we go forward too. Whatever you decide is your decision, and that's perfectly fine. I'm not going to judge you. I'm just feeling grateful that we have these resources to us to save lives and to save babies' lives. So they're there for us, and we are lucky to have them, surgery and NICUs. All right, so let's do it. Let's do this thing. Okay, well, one more thing. Sorry, I know all of this like housekeeping. Okay, so I'm going to keep the chat up during the webinar, so drop them in the Q&A sessions as they come up, or you can take notes and ask them at the end. We're going to leave about 15 minutes at the end to ask questions as well. I know I don't have to say this, but I do. Rudeness, judgmental words, meanness, racism, and shaming will not be tolerated. This is a safe space for everybody. We all have a common goal of elevating our birth and postpartum experience. So we're all here to help each other. Our stories are powerful. So if you are a second time mom, third time mom, fourth time mom, if you're a first time mom and you want to hear some positive birthing stories, we can all share our experiences, and I'll definitely share some of mine as well. So we can lean on each other and be supportive and just learn from each other. Whatever emotions you're feeling going into your birth are completely valid. If you are feeling nervous, if you are feeling scared, if you are feeling anxious, if you're feeling excited, if you're feeling like, oh my God, I just want this pregnancy to be over, if you're feeling relief that your due date is approaching, it's all valid and they're all important emotions. There's no such thing as feeling a wrong way. I had IVF babies. It took us 5 years to get my first one. And I felt so much relief after I had him, like that he was finally in my arms, that I was just like, I mean, I was happy, but I was also exhausted, which I'll talk about later. And I was like puking for 24 hours. But I was just like, I felt this overwhelming sense of like, okay, he's here. He's like out of me. Like I don't have to worry about like loss or anything like that. So everybody's emotions are different, and it's dependent on so many factors. So whatever you're feeling, share them with us. It's totally valid. Don't feel like you have to hold them in or not communicate how you're feeling towards your birth and all of this stuff that we're talking about. Okay. All right, here we go. Okay, so here's our outline for today. So we're gonna do basic pelvic floor anatomy. We're gonna talk about the pelvic floor muscles in the core, what is happening to that area during pregnancy, what has to happen during birth. We're gonna talk a little bit about Kegels and pelvic floor activity. And then we're going to talk about letting the pelvic floor go and how to do that. I'm going to give you a couple things to work on at the end of this session from like a functional standpoint, and we'll get to that when we get to the homework section. And then we're going to talk a little bit also about ACOG's guidelines for exercise and pregnancy, and how to kind of weave in some pelvic floor training with what you're already doing, whether it's exercise wise or work wise or whatever your kind of physical demands are at this point. Okay. I think it's really important to know about anatomy because we have to have an understanding of what these structures are doing and what their jobs are. Okay. If we have a kind of a good grasp on the demand on these muscles and what they have to do for us during pregnancy and birth, I think we have a better understanding of how to rehab them and how to like start to think about them now. And if we start to work on pelvic floor, not necessarily strengthening, which we'll talk about in a minute, but if we start to work on pelvic floor control and core activation and bringing in those muscles a correct way, then we tend to see a better outcome after delivery in the recovery standpoint, because we've already like laid down those motor programs and we've already started training those muscles. Okay. So today we're going to focus a lot on anatomy, function, kind of the basic stuff. And then next session, we're going to progress that a little bit and talk about specific prep techniques for the pelvic floor. But I want you all to kind of get a really good understanding of what your body is doing right now and what your pelvic floor is doing during pregnancy and birth. Okay. Any questions so far? Anything that you want me to address at this point? Or are we good to keep on trucking? Drop me something in the chat. Let me know if anybody has any questions. Nope, no questions. Okay. All right. Okay. So here's our pelvic floor. Okay. So this is a side view. What do you know about the pelvic floor? Drop me something in the chat. Let me know what have you heard about pelvic floor muscles? What do you know about them? What do you think about when somebody says your pelvic floor? Okay, so yep. Kristen says, I think about all the layers of muscle like at the bottom of a bowl. Yep. Carolyn says, not just your vaginal area, extends up into the abdomen. Yep. Good. Okay. So All true, and we're gonna talk about that canopy of muscle that hold your organs in. Yeah, girl, that's right. These muscles are amazing, and they have to do so much stuff. It's, like, unbelievable. They have to do way more than, like, our biceps or our quads or our hamstrings. I mean, these guys are, like, the mothership. So, let's talk about orientation real quick, okay? So, here is my pelvis, okay? You're gonna get to know her a lot. This is your pubic bone right here. So on the slideshow, it's this little kind of oval circle. The back here, we have our tailbone. This is our sacrum, low back or lumbar spine, and then here's our SI joints. Okay. So all of this red stuff that you see at the bottom of the pelvis is pelvic floor muscle. Okay. So in this side view here, we see that it slings from the pubic bone, which is here, your pelvic bone, all the way back to your tailbone. Okay. And then it also goes side to side. So these bones here, these white bones are your sit bones. They're called their ischial tuberosities. And the muscles, basically, there are three layers. They sit like a hammock or a bowl at the bottom of the pelvis. Okay. These muscles, all of this red stuff, all of the pelvic floor here is made up of skeletal muscle, okay, which is the same stuff as your bicep or your hamstrings, which means the pelvic floor muscles are at the same like propensity for injury, for overuse, for spasm, for weakness, for tightness. All the things that we experience in other muscles of our body happens in your pelvic floor, okay, or can happen in your pelvic floor. So just kind of keep that in mind as we start to go through and you learn about the demands on these muscles during pregnancy, okay? But because they sit in this orientation, okay, because they're like a hammock at the bottom of the pelvis, they never really get a chance to rest, okay, which we'll talk about later. We can't like put a boot like if you sprain your ankle or have shin splints, like you can put a boot on and like rest it for 6 weeks, right, when you have an injury. We can't do that with these muscles. So it's not shocking to understand that we see a lot of like longer term issues after pregnancy and delivery sometimes because we can't really just rehab the muscles the same way that we would rehab other muscles, okay? So there are three main jobs for the pelvic floor muscles. One is support. So it's holding everything in, and we'll talk about that in just a second. The second job is continence. So that's holding in urine, stool, and gas. And then that has a third, sexual function. Okay, so those are the three kind of main makeup function of the pelvic floor muscles. Okay, so the pelvic floor muscles have to do a couple different things from like a movement standpoint. All right. They have to shorten and contract. They have to be able to lengthen and open. They have to lift up towards our head. They have to be able to drop back down to baseline. They have to bulge a little bit. So this is kind of where we like bear down, which we'll talk about in another session as well, and kind of push poop or push a baby out. And they have different types of fibers within them, which are quick, like fast twitch fibers and slow twitch fibers. So these fibers, I call them like the sprinters and the marathoners, white meat and dark meat. So the quick, fast twitch muscle fibers of the pelvic floor help us do fast contractions up. So this is what keeps us continent when we sneeze, laugh, cough, jump, bend down to pick something up, run after a toddler, lift something heavy really fast. It's that increase in like quick increase of abdominal pressure that makes the kind of fast twitch fibers come back up quickly to support the bladder and the urethra and keep us continent. Okay. The slower twitch fibers, the marathoners, they're on longer. They're like our endurance fibers. So these are the types of fibers in the muscle that help us contract and stay continent as supported for longer periods of time. So as the bladder is filling, as we're walking to the bathroom, as we're on the elliptical for 20 minutes, as we're walking with a stroller, as we're going for a stroll in the supermarket. these endurance fibers have to work at the same time. So we have, as PTs and as mamas, we have to train both types of fibers in different ways. Okay, so when we're talking about doing pelvic floor training and pelvic floor prep work, we have to keep that in consideration and in the back of our minds. Like, we can't just do Kegels at a stoplight, squeezing our vagina for 10 minutes, or I'm sorry, 10 minutes, I can't even do that, squeezing our vagina for 10 seconds, because that's not training all of the fibers in the most optimal way. And it's not doing it in a position that is challenging. Okay. Questions about that so far? Did y'all know that there were different fibers and that they have different roles? Does that make sense to everyone? Yes. All right, Kristen, thank you. Makes sense. All right, sweet. Okay. Didn't know that. I know, right? Amazing. You guys are gonna be like vagina experts when we're done with this class. Okay. So let's talk about support for the first job. So we're talking about this in a non-pregnant body, okay? And then we'll kind of apply this to pregnancy as we go through. So the main supportive function of the pelvic floor is to support our organs, gravity, and our body weight, okay? Because remember, these babies are at the bottom of the pelvis, okay? So all of our guts, our organs, gravity, body weight, they all are loaded onto the pelvic floor from the top down, okay? They also have to support us by absorbing shock and ground reaction forces as we walk, run, and jump. And those forces that are generated when we step transfer up through the legs and into the pelvic girdle, okay? So these skeletal muscles have to basically be on all the time to keep us supported against gravity. All right. They can also help with core stability and back pain. So when we're talking about core, we also need to be talking about the pelvic floor, because that really is the floor of the core. And we're going to talk about this in a minute too. And it helps support the entire trunk and the entire pelvic girdle. Okay. And I've got a really great analogy that I'll teach you in just a minute. All right. Job number 2, continence. So continence is keeping us dry, right? So the pelvic floor muscles help to hold in pee, poop, and gas. Okay. And the way that they do that is by involuntary and voluntary control. So, for example, as the bladder is filling with urine in a perfect world, the pelvic floor muscles turn on, they contract in towards the vaginal canal and up towards our head. So this would be like a Kegel, okay, a shortening concentric contraction of the pelvic floor muscles, just like your bicep, okay? When you do a shortening contraction of your bicep here, the muscle becomes bigger, bulkier, and shorter, okay? Same thing happens in your pelvic floor. But instead of just being unilateral, one side, both sides of the muscles come in and they lift up. And because the bladder sits right here, kind of right behind the pubic bone, and the urethra is right here piercing through the pelvic floor, when these muscles contract in and up, they close down the urethra and the neck of the bladder, and they offset the pressure that is generated by the bladder filling with urine. Okay. So when we get the urge to pee, same thing with poop, there are stretch receptors, which are these special nerves that are inside the wall of the bladder. As the bladder distends with urine, the stretch receptors are activated, gives us urge. We're like, oh, okay, I have to go pee now. Time to go pee. Pelvic floor muscles turn on even more to get us to the bathroom. Then we take our pants off, we sit down, pelvic floor muscles relax and open. So now they do the opposite, and the bladder muscle pushes urine out. Okay. Same thing with pooping. All right. There's a muscle that goes around the rectum and around the anus. And we also have sphincters within the pelvic floor muscles that are a different type of muscle. They're called smooth muscle. And these ones work under involuntary control. Like, we can't tell our urethral sphincter to contract on demand, but we can tell our pelvic floor to contract on demand. So they have to work together and in synchrony and in concert to really provide the biggest closing pressure for the bladder and the rectum. But same thing when we have to poop. Poop comes down, it stimulates a reflex that gives us a sensation of pressure, or that's something that we have to poop. The sphincter contracts, pelvic floor muscles turn on, we go to the bathroom, pelvic floor muscles open and lengthen, poop comes out. Okay. And we'll talk about that a little bit more too, because that's part of our homework assignment. I'm going to teach you about pooping and how to do it so we don't put excess pressure on the pelvic floor, which will help with pushing and prolapse after baby. Method to my madness, y'all. Okay. And then gas, of course, keeps gas in after baby. Okay. So the third function is a sexual function. So the first layer of the pelvic floor muscles here attach to both sides of the clitoris. Okay, so here's the clitoris. See how these muscles are kind of like, it looks like a triangle? This is the what we call the urogenital triangle, and the first layer of pelvic floor muscle. They attach to both sides of the clitoris and they assist with the rhythmic contraction of orgasm. Okay, so like that kind of pulsating sensation that you feel with orgasm is due to these muscles helping the clitoris climax. The second function for sexual is that this muscle around the opening to the vagina here, it's called the bulbospongiosus, it's like a horseshoe, and you can kind of see it on the diagram here too on the slide. It's underneath this skin right here. Okay, it's like a horseshoe. It has to lengthen, open, and release in order to allow penetration through the vaginal canal. If you are engaging in anal sex or penetrative sex on the anus, same thing. Pelvic floor back here has to open and lengthen in order to allow space to come in, or in order to allow space so something can come into the vaginal canal. Okay? It's a twofer. It helps contract for orgasm and then it helps release for penetration. So when we're talking about normal and we're talking about normal pelvic floor function, there's a couple things that we need to keep in mind. We need to have full range of motion of muscle contraction. Okay, so a muscle has to be functional through its entire range of motion. And what that means is that a muscle has to be able to contract fully and it has to be able to relax fully. Okay, so when we read things and we talk and we hear things about like, do Kegels all day long, or hold in your pelvic floor while you're running, or squeeze your vagina 900 times when you're watching Bridgerton. It's like, that's not functional and it's not normal range of motion. Happens to me all day with my dog. I know, girl. So annoying. It's not normal and it's not full range of motion of muscle function. Okay. So, for example, for your bicep, when we contract our bicep, our arm is functional when the bicep goes through its entire range. Okay, right? If we are contracted all the time, my arm is not functional, this bicep can't work. And if it's extended all the time, my arm is not functional and the bicep can't work. It has to be able to move through its entire range of motion. And for the pelvic floor, that means that the pelvic floor muscles have to be able to go through all of those movements that we talked about earlier, which is contraction in and up towards your head, release down to baseline, and then a bulge. Okay, it's like think about like levels, or you're going up an elevator. Okay, like at rest is like the ground floor, the lobby, and then you go up a level and up a level, and then you come back down to the ground floor, and then you go down to the basement. Okay, the pelvic floor has to go through that entire range in order to be functional, and 100% has to be able to do that for delivery. Okay, more so the basement, which we'll talk about, but you'll get a better bearing down and pushing and lengthening if we can get the muscles to be functional through its entire range of motion. Okay, so that's normal. Being able to be strong and working at the correct time and timing through full range of motion. The pelvic floor muscles need to be under voluntary and involuntary control. That means that we tell them to do something, and that means that the smooth muscle or the sphincters are doing things automatically on their own. It's normal to be continent. Okay, we should be dry. There's always going to be, a little bit of a gray area, especially during pregnancy, because we have so much more load on the pelvic floor, which we'll talk about in a minute. But normal function of the pelvic floor is to keep us dry. Okay. We shouldn't be leaking urine if if we don't want to be. We should only be voiding when it's time to void. We shouldn't be leaking urine when we're walking, jumping, exercising, any of those times. Same with stool or fecal matter, we should be able to hold that in. Now, of course, if you have like a stomach bug and diarrhea and watery stool, that's always harder to hold in. But on a daily kind of normal functional basis, we need to be continent and dry. That's a normal functioning pelvic floor. People ask me all the time, like, what is normal for peeing? Like, how many times a day should you pee? If you're not pregnant, optimal voiding is 5 to 8 times within a 24-hour period. Okay. And it should be proportionate to the urge that you feel. And it should be proportionate to what type of fluid and how much fluid you are intaking. Okay. So if you have like a huge urge and like only a little bit of pee comes out, or if you feel like you're going frequently throughout the day and you're not voiding all the way, or you always feel like there's something left over, or it just doesn't make sense with how much you're drinking, then there might be a disconnect between function of the pelvic floor and what your bladder is doing. Okay. Normal is to have support of the pelvic floor and support of the organs. So we don't have prolapse symptoms, which we'll talk about in a minute. And everything is kind of where it needs to be from a functional standpoint. Vaginal penetration should not be painful. Tampons, speculum, vibrators, penis, fingers, whatever is going in there should not be painful. Okay. Unless you want it to be. But generally speaking, sex and tampons and speculum should not be causing pain. If there is pain and inability to do that, then there's something happening perhaps with the pelvic floor that we need to address as well. And then you should have kind of normal bowel movements without a lot of pushing or straining, bulging eyeballs, bleeding out of the rectum. You should be going every day or every other day, not like big, huge, hard stools. Ideally, a normal optimal stool is like a banana or a soft serve. There's actually something called the Bristol stool chart that has like diagrams of what your poop should look like. And the best one is like a banana. Okay. So that's normal. Now there's always variation. And, if you're not following, if you have some symptoms that I talked about and you're not totally like all of this, it's okay. Everybody's a little bit different, but this is kind of just a general checklist of what a normal pelvic floor is doing. Okay. Not in pregnancy. Okay. Let's talk about pregnancy. So this is a picture of a model. Okay. That's what this little metal thing here is like. It's holding the baby in. So we talked about support, right? And what these pelvic floor muscles have to do in a non-pregnant body. Okay. Now let's add in the baby, placenta, uterus that's grown 10 times its size, increase in blood volume, increase in weight, gravity, fluid, maybe another baby. All of that increased load puts demand on the pelvic floor, obviously, because the pelvic floor is the bottom and the floor of our core, and it was supporting all of those structures prior to pregnancy, and now we're adding more onto it. Okay. In addition, they don't get to rest, and that happens for 9 months. An increase in load and it kind of like a increase in demand. So as the baby is getting bigger and as you're progressing through pregnancy, the load is increasing on the pelvic floor. And sometimes the pelvic floor can't quite meet that load at the same rate. And then we start to see symptoms. So that could be like constipation or leaking urine or back pain or kind of all these things that could be related to pelvic floor issues. Okay. Now, on this model here, on this picture, right here, this white blob is the pubic bone. So pelvic floor muscles, see that little guy right there? That's like a cross section of the pelvic floor. Remember, they sling from the pubic bone all the way back here. This white stuff is what we call the anorectal fascia, and that's kind of how the muscles attach to the tailbone, but the pelvic floor muscles are right here, like a hammock, okay? So they are supporting everything, and all of that pressure down are resting on these little group of muscles right here, okay? That's a lot of demand on them. Think about that for your bicep. Like, what if we had to carry around something on our bicep for 9 months that was just getting bigger? I mean, that's a lot of pressure and demand. The load increases exponentially on these muscles, okay? And then for birth, they basically have to do the exact opposite, which we'll talk about in a minute, and then they have to come back to function and what they were doing before. It's like no other muscle in our body has to do that. So it's pretty amazing how important the pelvic floor is and how little attention it's given during pregnancy and birth and postpartum. Am I right? I'm right. Okay. So in addition to all of those other kind of increase in demands on the pelvic floor, we also have hormone shifts, right? So as you're pregnant, hormones kind of peak and add in, and we get new hormones and progesterone changes and estrogen and relaxin and all these things start to kind of go all over the place. And the goal of all these hormones is to prepare your body for delivery, to make things open and move a little bit more. Okay, so we see more ligamentous laxity, we see more kind of stretchiness, stretch marks happen. These hormones allow muscles, joints, ligaments, kind of all of these soft tissues to just be a little bit more mobile. So, a millimeter here, a millimeter there is just kind of enough shifting and movement in the pelvic floor and in the pelvic girdle to allow the baby to descend through that bony pelvis. Okay. But that also will change the level of support and the level of function of the pelvic floor. Because now, if they're just like a little bit more stretchy and a little bit more elastic than they used to be, they might not be generating as much force and pressure when they're doing contractions or when they're trying to keep you continent because they've like lost a little bit of that rigidity. Okay. So relaxin usually gets blamed a lot. Relaxin is definitely part of the puzzle, but it's also progesterone and some of the other hormones that are going on too. Okay, but all perfectly normal. These are all changes that are supposed to happen, but just think about like how they're affecting these structures and how they could be affecting how you're moving and how you're able to contract and get the pelvic floor and your core going. All right. Questions about any of this so far? All right. So this is just another picture of the baby nestling in the pelvic bowl. Okay. So again, here are the pelvic floor muscles. All right. So in order to allow the baby to exit the birth canal, these pelvic floor muscles here and this opening of the vaginal canal have to stretch and lengthen to basically the circumference of the pelvic bowl and the size of the baby's head and shoulders. Okay. Because these are bony parts. Like this can't go anywhere. Like it's a limited space in here. So the baby is confined by the size of the pelvic outlet. Okay. And the tailbone. So the this area here, the vaginal opening, and these muscles lengthen and stretch this way to allow the baby to exit. Okay. So that's a huge role and huge demand on the pelvic floor for birth. All right. And crowning is what we call when we first start to see a portion of the baby's head at the vaginal canal or the birth canal, we call that crowning. And then obviously, as the baby descends further, and we'll talk about this as we go in our midwife lecture, then we see more of the head. I remember with my first baby, I had a mirror I wanted to see because I'm like super nerdy and I wanted to look at my vagina during delivery. And I remember I saw like a little bit of his head, like right when he was crowning and right starting to come in. And it was like maybe like this big. It was like not very big. It was like that. It was maybe like the shape of an egg, maybe the size of an egg. And I was like, oh, I got this. I can push that out, no problem. Like that's piece of cake. Like not totally fine. It was like this much of his head. It was like, and then when he started to come down and like his whole head started to crown at my perineum, I was like, oh, that's like a gigantic human head coming out. I'm not just like getting, it's just not like an egg. It's like an entire human is coming out. Okay, got it. So, like, as you start to go and as you start to see the baby crown, this first layer of muscle here will stretch and open. Okay. And this is called the perineum. And tomorrow, or not tomorrow, next session, we're going to talk about perineal massage and ways to prep this area and some tearing, like what tearing is and what episiotomy is and that sort of thing. But usually we see tears here because as the baby is coming out this way, this muscle gets stretched and this tissue gets stretched here. Okay. And then after the baby is born, the muscles have to come back together over time. And sometimes a repair is done, which we'll talk about later too. But that's a lot of demand and a huge responsibility on the pelvic floor muscles. Okay. So just kind of think about that moving forward, like how amazing these muscles are. I mean, it's just like, it's so amazing. They are, oh, they're the best. Okay. So some other changes in pregnancy. So our spine will move a little bit more forward, okay, which will extend our abdomen, shorten our hip flexors, and give us a little bit more of what we call lordosis in the physical therapy world, which is an excess curve in the low back. Some people call this sway back. Some people say increase in extension. But what this does is as the baby is growing forward and in front of us, it kind of pulls the spine into more of a curved shape, into more of that extension. And that will move your entire center of mass and center of gravity forward. And that will impact the way that we balance. So pregnant women sometimes have a little bit more of like a higher risk for falls, tripping, that sort of thing. This can also increase pressure on the pelvic floor because now not only do we have all of this extra weight and load, but we also have a baby's head right here that's pushing on the bladder, which can give us a little bit more urge. Bladder can't fill all the way, difficulty with holding urine in. And we might see a little bit more leaking, especially with transitional movements, sit to stand, coughing, laughing, sneezing, that sort of thing. Okay. It also is going to change the way that we're able to breathe. Okay. Because now we have a baby up here. Our diaphragm is kind of smushed up. Our lungs are smushed up. Our guts and everything that normally sit down a little bit lower in the trunk are now smushed all the way up this way. It's harder to get a big breath of air. We might be having some reflux. And the breath and the pelvic floor are super important because they move together. They're the diaphragm and the pelvic floor are linked. So proper pelvic floor functioning does a lot better when we have proper breathing. And when we're pregnant, it's hard to have proper breathing because our lungs just don't have the space or the real estate to do that. Okay, so we might see more pelvic floor issues because that breath and pelvic floor movement isn't as robust as it used to be. Okay, and then we talked about the ligamentous laxity. Okay, so here's the core. We're going to kind of go quickly through this because I want to make sure we have time for questions. So the core is made up of your abdominals, okay, your pelvic floor, which is down here, and a muscle in your back called your multifidi. The top of the core is the diaphragm, so that sits right underneath your ribs here, and it's like what pulls the lungs down and contracts up to expel air. And then the bottom is your pelvic floor. It's like a soda can. Okay, this is important because we are going to talk about this when I teach you how to push and how to bear down the right way. So you have to think about like the pelvic floor and the diaphragm moving together and that it's a closed system. So when we push or bear down or start to like get the baby out of our vagina, we are generating pressure from our abdomen coupled with uterine contractions to bring the baby down. Okay. When we are working on the core after baby, we have to incorporate all of these structures, abs, pelvic floor, breath, and back muscles to really support our body and rehab appropriately. Okay, so even now, if you're doing core exercise, all of these pieces, breath, pelvic floor, abdomen, and low back, have to be working together for a functional system. Okay, so let's talk about Kegels really quick. So, what's a Kegel? Let me know in the chat. What do you guys think Kegels are? Pelvic floor contraction. Very good. Flexing parts of your pelvic floor muscle. Contraction of pelvic floor muscles. Yep. So remember, Kegels are contracting and lifting up, okay, to increase support and keep us dry. So we do them for all of those reasons: continence, supporting our core, mitigating abdominal pressure, keeping us dry. All of the functions that we talked about earlier can be um, complemented by a proper pelvic floor contraction. Okay. Now, the reason why we do them is because it helps our posture, helps our core get strong, keeps us dry, and it aids in motor control training. Okay. Which means it's the link between your brain and your pelvic floor muscles. So the cues that I use when I teach people Kegels are different for everyone. These are my favorite ones. One, I say, you want to think about picking up blueberries with your vagina. Okay. You're not squishing them and making jam. You're just very gently grasping a blueberry with your vagina and lifting it up and in towards your head, like kind of drawing up. Okay. You want to squeeze those muscles like you're holding in gas. You want to think about like puckering your anus or winking, stopping the flow of urine, or sucking up a smoothie through a straw with your vagina. Okay. So that's all verbal cues to help kind of engage and lift up. Okay. For doing Kegels. Now, I'm going to talk to you about this in just a second about pregnancy and what you should be doing now. But I want you to just think about doing one like right now and see where you are. Do you feel it lift? Do you feel it drop down all the way? Does it tire easily? Does it hurt? What does it feel like? Can you feel it lifting up? And I want you to think about doing it without holding your breath. Don't squeeze your butt muscles. Just really try to isolate vaginal and anal muscles and really think about lifting up and in towards your head and just kind of see where you are, what your baseline is like. If you'd like to report it in the chat, you let me know. If you don't want to, that's fine too. So, when should we do Kegels? We talked a lot about, or I talk a lot about these like red light Kegels when we're told to do them, sitting at a stoplight. I don't like doing that. I like to train my pregnant mamas to start to do Kegels in functional situations. Okay. So if you are currently pregnant, which all of you are because you're in prep and prevent, you should be thinking about doing Kegels more with functional everyday activity than just sitting like at your desk or sitting at a red light. Okay. So think about like every time you go from sit to stand, before you do that, you do a pelvic floor contraction and then you stand up. If you have other kids at home, if you have to bend down and lift up a toddler, pelvic floor and abdomen come on, lift your toddler, then let go. Think about adding this in with activities that increase pressure and load on the pelvic floor because you already have that increased demand from pregnancy. So now we need to make sure that the pelvic floor can, one, support it, and two, come on when we need it to come on because we're increasing the demand even more. Okay, if that makes sense. This is all, even though it seems like super boring and it's like, oh my gosh, I'm never going to remember to like do a Kegel when I go from sit to stand. This is all going to help postpartum after the baby comes. One, because you're already in the habit of doing it, so your body's going to pick it up quicker. And two, this is more opportunity and more repetitions for you to do pelvic floor contractions. So you're going to build up a little bit of strength and resilience in your pelvic floor going into postpartum and delivery, which is great. Now, like, should you be doing Kegels in pregnancy? Like, isolated ones, totally depends. I don't prescribe isolated Kegels a lot for my pregnant clients unless they're coming to me with some like leaking, prolapse. They have weakness and supportive issues either from previous deliveries, and we need to build up strength. But usually for my first time moms, we do more functional Kegels, like I talked about, and then we work on relaxation. Okay. Also depends on what your exercise level is like, what your awareness of your pelvic floor is, what your baseline is, and kind of what you're doing from everyday activity standpoint. Okay. Does it count as a Kegel if you do it during sex? Okay, so Jessica says, doesn't count as a Kegel if you do it during sex. Like with an orgasm or just doing it because it feels good, like penetration, around penetration. Yeah. I mean, it's a pelvic floor contraction. So yeah, for sure. I mean, it's it's a shortening concentric Kegel contraction. So yeah, that would be considered a Kegel. But and that's fine. I mean, if you like to do that, a lot of people like to do that. The partners like it too. It kind of gives them a little bit of feedback. But yeah, I mean, that's doing a contraction. So go for it, sister. But we also need to work on relaxation because remember, the pelvic floor has to be able to lengthen and open for delivery. So in this picture here, I think they have like saran wrap on the model's head to show like the vernix, which is that like waxy coating, or either the amniotic sac. I'm not quite sure, but remember, this baby is going to exit through this vagina. Okay. And this vagina and these muscles around it have to stretch and open to the circumference of the pelvic rim. So Kegels do not push a baby out, right? The pelvic floor has to get out of the way. So contractions from the uterus and pressure from the abdomen during bearing down and pushing, which we're going to talk about in another session, are what help the baby descend. Kegels don't do that. So even though we practice Kegels from a functional standpoint during pregnancy, we also have to focus on lengthening and softening so the baby can come out. Okay, so strengthening is important, but so is releasing and lengthening. There's only so much room in there. Like these bony prominences are really the confines of the pelvis. Okay. And remember, because of these muscles are skeletal muscle, they can have the same sort of injuries as other muscles in our body. And if we overdo it with exercise like Kegels, they can have the same type of injuries like shin splints or overuse or spasm, or it's like sometimes if you wake up in the middle of the night with a Charlie horse in your calf, like that can happen in the vaginal muscles as well. So we don't want to overdo it with only strengthening. We also have to train it to lengthen and open too. Okay. So these muscles are just like any other muscle. Like we got to take care of them and we can't overdo it. All right. Let's take a 1-minute break. Get up if you need to, stretch, pee, drink some water, look at those cute babies. Send me a question. Anybody have questions so far? Yes, Kristen, tell me what's up. She's typing. Gosh, I love like those little hats, those blue and pink striped hats. Oh God, they're my favorite. So sweet. Get them at the hospital and they're like, it's a little. I want to see every single picture of your babies, by the way. I want to look at those babies so I can live vicariously through you. If anybody else has a question too, just drop it in the chat. Let me see if anyone put it in Q&A. Okay, no good. All right, Kristen, I'm going to keep going, but when your question comes up, I'll answer it, okay? Just because we're running short on time and I want to make sure we have times for other stuff too. Oh, can you recommend any online prenatal exercise videos? Yes, ma'am, I sure can. I will put that in the Thinkific site as well. So I really like Body Fit by Amy. She's one of my favorites, and she has great pregnancy and postpartum workouts, and we send a lot of clients back and forth. So her stuff complements my stuff. And when you guys do foundations after baby, because you'll get into the foundations course, then after you're done with foundations, her stuff is like the perfect gateway. So Body Fit by Amy is really good. She's kind of my favorite. And then I'll put some more links up in the Thinkific course tomorrow under the text page. Okay. But she's my prenatal. She's my fave so far. Okay. All right. So here are just some ACOG guidelines for pregnancy and exercise. I have this link up in Thinkific as well. So ACOG wants you to, oh, here we go. Kristen says, I went to a pelvic PT before I got pregnant. She said I was actually tight and needed to come in during my third trimester to loosen. I am not having continence issues and wanted to know if that's normal during pregnancy. It started happening early with major morning sickness with leaking urine. Yeah. So, okay. So, yes. So, vomiting, coughing, so we see a lot more leakage sometimes like during cold and flu season. And obviously, after you have stomach flu or morning sickness, because vomiting is a very forceful, involuntary pressure and increase in abdominal pressure down on the pelvic floor. So when you're vomiting and generating that sort of contraction this way, the pressure will like push down on your bladder, and oftentimes the pelvic floor isn't strong enough or isn't doesn't have the correct timing to counteract that. So going back to kind of function of the pelvic floor through through the entire range of motion, we do see leaking with muscles that are too short. Okay, so like if your muscle is tight or short, it's not able to contract and move through its entire range of motion to support the bladder and the urethra. Okay, so you can have a weak and short muscle. What we want is a long and strong muscle, but we do see leakage and other problems with muscles that are too tight for sure. So it's not uncommon. And when next session, Kristen, when we start to do some of the pelvic floor relaxation stuff, and week 3 in foundations talks all about like lengthening and opening and exercises to release the pelvic floor. And next week we'll talk about other ways to start to drop it down and do some manual work for perineal stretching and perineal massage. And oftentimes what we see once we start to do that, if there is a tight pelvic floor, then we see some of the continence issues resolve because now the muscle's like freed up to go through its entire range of motion. Okay. And this is exactly why I don't tell everybody all the time to do like hundreds and hundreds of Kegels, like you might hear on social media or in Cosmo, because your muscles might be tight. So for all intents and purposes, I think it's really important that we do like functional pelvic floor contraction and work on the relaxation part too. Okay. Does that make sense, Kristen? Okay. So, good. So, ACOG guidelines for pregnancy, they recommend 150 minutes of moderate cardiac exercise per week. So this is where you can still talk, but your heart rate is elevated. You're not out of breath, but you can't sing is kind of the guidelines that they use. ACOG also says that you can continue the level of exercise that you were doing prior to your pregnancy until you just can't or feel uncomfortable. Pregnancy is not the time to train for a new activity, train for a race, increase your mileage, try to PR on your weightlifting. You kind of want to stay at what you've been doing until you feel like you can't do it anymore. Nothing where you can fall or be struck in the abdomen. Horseback riding, skiing, road biking, tennis, that sort of thing are not recommended. And then I put a link up in Thinkific that has the full guidelines with FAQs on ACOG's safe guidelines for pregnancy and exercise. Now, if you are exercising during pregnancy, which is recommended, there's a couple things to think about. I've had so many mamas tell me, like, when they've seen me postpartum, they're like, man, I wish like I just had stopped running during my third trimester. I was like leaking the whole time. And now I worry that I, like did more damage. And it's hard to say, like, we can't go back in time and we can't, change anything in the past. But just know that as you are increasing your exercise or going through your pregnancy and the baby's getting bigger and all of that load is increasing and the demand is increasing, running can increase intra-abdominal pressure up to 2.5 times more than normal. Okay. So adding that 2.5 times more than normal plus the added demand of pregnancy can lead to weakened muscles, prolapse, leaking urine, that sort of thing. So it is different for everyone. I have had patients who have like run marathons like up until the beginning of their third trimester and haven't had any problems. So it is different for everyone, but just from like a physics and body mechanics standpoint, there is already extra load on there. So just keep that in mind as you're continuing to exercise or do your activity. I'm not one to say, like, don't do anything. I think it's important to move and be healthy and do what you love doing. If running makes you happy, if biking makes you happy, if you like to, exercise, it's great benefits for the mom and the baby to have that sort of cardiac exercise and to continue to lift weights. But just be mindful of how you're doing it, making sure that you're bringing your pelvic floor on appropriately. You're not holding your breath. You're contracting your abdomen in a safe way. You're not pushing or bulging or straining. You don't have symptoms during these activities. Like if you're noticing that you're leaking or you feel like things are falling out of your vagina when you're running, then maybe that's a sign that we need to kind of scale back a little bit. Okay. And then we talked about short versus weak pelvic floor. Like we don't want a super tight muscle and we don't want a super weak muscle, right? We need a functional muscle through its entire range of motion. Okay, so these are some of my favorite exercises in pregnancy. They're great for your pelvic floor and really good for you as a mom and like your cardiac health. Swimming, it's awesome. And the water and the hydrostatic pressure of just being in the water will help with swelling. Stationary bike or Peloton, just because I'm like nervous that if you're on the road bike that you'll fall or somebody will hit you and it's like blah, too scary. Modified yoga or Pilates. Body Fit by Amy does a great kind of Pilates uh, modified for pregnancy. You just want to take into considerations of the abdominal wall. I don't love in pregnancy to like do a lot of overextension and stretching up like a really aggressive cat up dog or cobra or like a back bend or over a ball. It's just a little bit too much stretching and the lengthening of the abdominal wall. Um, is stationary bike okay with pelvic floor dysfunction? What type of pelvic floor dysfunction, Brie? It's different for everyone, and we can address that too, more specifically. Walking is great. Just make sure you're in good shoes with support, sports bra to hold the girls in. If you need belly band or support leggings, I put some links up on Thinkific of my favorite companies, and you want to make sure that you're staying hydrated. Bar classes, body weight lifting, full whole body functional kind of big movements are some of my favorites too, as long as you're not experiencing pain, leaking, vaginal heaviness, that sort of thing. Okay, so whatever it kind of makes you happy and you like to do, but also you're making sure that your pelvic floor is on and supporting you because you don't want to be doing things in pregnancy right now that are putting too much load and pressure on the pelvic floor that might predispose us to like prolapse and leaking after baby because we still have to get through the rest of the pregnancy and birth and pushing. And so we just want to make sure that we're starting at a good point. Okay. So if you need a little bit of extra support around the pelvic girdle, there's a great belt out there called the Sorolla belt. I'll put those links up as well. It's made for pubic bone dysfunction, and kind of SI joint pain here. So it's not a pregnancy belt. It's more of like an SI belt. So it goes around the pelvic girdle and just gives you a little bit of lateral compression. Super great with pregnancy because it sits under the baby. And it's really helpful for people that are on their feet a lot. So like nurses, teachers, when you're up walking around, the belt is helpful to just give your hips and your pelvic girdle a little bit more support. You don't need to wear it when you're sitting or laying down. SRC Health has great leggings for pregnancy and postpartum. So does Beobe Maternity. The V2 supporter is kind of like a female jock strap. So if you are having like swelling, vulvar varicosities, any sort of like perineal pain or specific prolapse, like rectal prolapse, or like just kind of a lot of fogginess and engorgement, the V2 supporter is a garment that you can wear over your underwear to just give you a little bit of compression up around your perineum. And then everybody needs to be in compression socks. Grade 1 medical compression up to your knees. reduces the risk of DVT, helps with swelling, especially if you're on your feet all day as a nurse or working in healthcare. Super important that you're in compression. Okay, so good pelvic floor habits that I want you guys to start working on today. Okay, so this kind of goes into your homework. So I want you to add in functional pelvic floor contractions. So every time you get up from the chair, when you're rolling over in bed, I want you to think about lifting your pelvic floor, exhaling on exertion. So we're not closing our throat and bearing down. We're not like, ugh. That puts too much pressure down on the pelvic floor and can contribute to leaking and prolapse. Okay. So think about drawing, Bree, yes, I will answer that at the end for sure. Just remind me, okay? So you're thinking about drawing kind of the baby up towards your spine a little bit, kind of lifting up the baby, pelvic floor contraction, exhaling at the same time, then roll over in bed, then get up from laying down, then get up to stand. Do all of that first. I call it the foundation, and you'll get this when you go into foundations as well. Think about setting that before you do those activities. Same thing with laugh, cough, or sneeze, especially during the later stages in pregnancy when you have so much pressure and so much weight down on the pelvic floor. Okay. You really want the pelvic floor to turn on to counteract that. Okay. Try not to push or strain to poop. Okay. You want to think about open mouth breathing, fogging up a window, or blowing out a candle when you're pooping. And I have a diagram on Thinkific for you there. The knack is just starting to get your pelvic floor activated prior to laugh, cough, sneeze. So we make it habit. Okay. So if we start to think about getting those quick fibers in before that quick increase in abdominal pressure, over time it will become habit. Okay. And we want to link the breath. So make sure that you're exhaling with exertion and contracting your pelvic floor at the same time. Okay. Same with posture. Watch your posture when you're pregnant. I know it's super hard, but the more forward we're out and the more increase in low back, the more pressure down on the pelvic floor. So just make sure that we're doing a little bit of like general pelvic mobility exercises, which we'll talk about in the next couple sessions. Some cat camel, some pelvic rotations, some flexion, just to open your spine and keep it moving. Okay. If you're standing a lot for work, if you're standing at a standing desk or typing standing up, or if you're sitting a lot, make sure that you have pillows to support you, feet flat on the ground. Your computer is set up at a good angle, 90-90 for hips and knees. If you are standing a lot, if you put your foot up on a stool, just raise it a little bit off the ground. That will automatically open your pelvis up and just kind of tuck your booty a little bit under, and it feels awesome on your back and take some pressure off of the pelvic floor. Okay. Okay, so here's homework. So functional pelvic floor contraction with exhale, all three components of your foundation. So that's pelvic floor, exhale, abdominal contraction, gently bringing the baby up towards your spine. Body mechanics without holding breath and pushing out. So if you have to lift something heavy, you want to make sure that you've got your foundation engaged and you're not pushing and straining and like really like coming down on the pelvic floor. Okay. I'm going to teach you how to push and how to bear down with your open mouth. So we decrease the amount of load that can contribute to prolapse and leaking. Okay. And then I want you to just start to practice your range of motion for pelvic floor. See if you can do like a little contraction, a little bit more lifting the blueberries, back to the lobby, and then very gently kind of bulge to the basement. Try to almost feel like you're trying to feel the seam of your underwear with your pelvic floor. And then back to the lobby, and then back up to the first floor, second floor, down to the first floor, down to the lobby, and then bulge to the basement. Okay? And then pooping, I want you to, I have a handout here on the downloads too. Feet up on a stool so your knees are higher than your hips. Forearms go on your thighs. Lean forward, blow out through your mouth. Okay? No closed glottis, bulging eyes, straining to poop. Okay? It should be gentle. Think about your vagina and your mouth as one tube. Okay? And you need airflow, air exchange, pressure exchange. Okay? If you close this off, all of that pressure will come down on your pelvic floor and increase your risk for prolapse and leaking. Okay? So you want to have like pretty even pressure exchange. while you're pushing. While you're pushing. So you still get the bulge of the pelvic floor in the opening, but it's not like forcing down. Okay? That's your homework for this week. Okay, next session, we're gonna take this up a notch. We're gonna talk about perineal massage, episiotomy versus perineal tears, remain calm. It's gonna be just fine. I'm gonna talk a little bit about instrumental delivery, so vacuum and forceps, kind of what that looks like, why that is used and indicated. I'm going to show you some stretching and pelvic floor release exercises that you'll add into your repertoire. We'll talk about bearing down and push training, labor positions, medicated versus non-medicated, some partner-assisted labor positions, and then positions for birth, medicated versus non-medicated. Okay, so that's coming up next Tuesday. Questions? 15 minutes over. Dang, sorry, y'all. Okay, let me answer Bree's question, and then if somebody else has a question, you can put it in the chat. Otherwise, drop it in the Facebook group or bring it to me on Thursday. But Bree asked, is stationary bike okay with pubic bone dysfunction? It's painful right at the center of the pubic bone and hurts to walk towards the end of the day. So I think it depends on a couple factors. If it's hurting you when you're on the bike, then I would say like probably scale back a little bit. Sometimes the bike, like the upright bike might be a little bit less painful. Like the recumbent bike where you're sitting with your back, we tend to like kind of splay our knees a little bit more. Yes, any and all questions, Jessica. She says, I know there's a Q&A on Thursday. Is it open to any and all questions? Yes, any and all questions, every Q&A. All questions, ask me. So with the recumbent bike, sometimes our knees like splay a little bit more, which puts more pressure and opening on the pubic bone. So the upright bike can be maybe a little bit more comfortable. But think about like avoiding situations where you're really like stretching one leg out from the other. So like yoga can be aggravating sometimes for pubic bone dysfunction. When you get into the car, think about like one leg into the car. You want to think about like eliminating those kind of single leg positions or like stride stance positions. So when you're getting in the car, for example, you'd like back up, sit your booty down, engage your foundation, pelvic floor, lower abs on, and then like bring your legs in. Same thing with rolling over in bed. Okay, so think about starting to engage that first and then doing the motion. The Sorolla belt can be helpful for pubic bone dysfunction too, because it just gives you a little bit of that support. So if it's bugging you towards the end of the day, you might think about throwing the Sorolla belt on right before it starts to get painful if you have like whatever you're doing that day, if you're going to be on your feet. Okay. First session down. Nice job, guys. I hope, did you link the Thinkific site in an email already, or is that coming? Carolyn, you should have, that's where you created your account, your student account. So go back to, and like where you paid for the course. So yeah. So you can access Prep and Prevent now, and I will drop all of this in there so you can rewatch the video, get all the downloads and links and that sort of thing, and it's all in one place. Kristen, are you still in the clinic? Nope, I'm not. I'm all online now. Everything is virtual. So I'm doing all courses, virtual sessions, one-on-one virtual stuff, consulting, brand consulting, that sort of thing. Maybe when COVID's over and my kids are a little bit older, I'll get back in the clinic. But I sold my clinic in Los Angeles when we moved last year. So I was like, perfect time to go online and reach more mamas. All right, guys, thank you so much. Great first session. If you have any questions, don't hesitate. And I'll see you next Tuesday, but first on Thursday for the Q&A. All right, everyone. I will talk to you. You're welcome. Have a good night, everyone. I'll talk to you later.